Today's webinar is titled New EMS Model Guidelines for OB Emergencies, What Educators Need to Know, presented by Dr. White and Dr. Zahn. Dr. Christopher Zahn is the Chief of Clinical Practice and Health Equity and Quality at the ACOG, and Dr. White is the Chair of ACOG Obstetric Emergencies Initiative, Professor, University of New Mexico, Department of Emergency Medicine. I will pass it over now to Dr. Zahn to go ahead and get us started. Thank you both so much for being here today to share your knowledge and experience with us.
Thank you very much, Rio, and thanks to everyone for being on, and as well as the organization. We very much appreciate the opportunity to talk with you today. So I'm going to start off with a background of the project, as well as a brief touch on maternal physiology that ties directly into some of the guidelines that you're going to hear about. Next slide, please. This is our standard disclaimer, so we can immediately go to the next slide. So why are we paying attention to this? And we know that pregnancy-related mortality has definitely been on the rise for a number of years. And although there are multiple efforts across the country, as well as regionally and locally, to try to address this issue, it's a multifactorial problem that's going to require a multidisciplinary approach. And we know, again, that the rates are still rising. And this is just an example of some CDC collected data to demonstrate that. Interestingly, there was a pretty significant bump several years ago because of COVID, but certainly the rates continue to go up disturbingly. So next slide, please. When you look at pregnancy-related mortality causes, and this is data obtained from the maternal mortality review committees, which are state-led committees to review maternal deaths, to try to determine the cause, and even more importantly, if the death was preventable. This lists, this is the most recent data listing the primary causes of death. And interestingly, this year, infection took over as the leading cause, and that's because of the contribution of COVID mortality demonstrated on the last slide. But when you remove COVID, mental health conditions are still the leading cause, but certainly hypertensive disorders, cardiovascular disease, hemorrhage also are significant contributors to maternal mortality, and particularly preventable maternal mortality. So it's really important to have this information so we know what we can try to target to reduce these preventable maternal deaths. Next slide, please. I think a really important consideration, certainly when I trained, the postpartum period went out to 6 weeks postpartum, and that was it. And it was almost like patients just went into a new life beyond pregnancy in the postpartum period. But we know from some of the NMRC data that the risk of death continues beyond the traditional or first 6 weeks, and that actually a sizable proportion of maternal mortality occurs after that initial 6 weeks up to a year out. So certainly ACOG and a number of obstetric organizations have really pushed hard to try to get the postpartum period extended out to a year, the consideration of that. And it's so critically important, again, to recognize that deaths can occur beyond that traditional earlier time period. And the other really important aspect is the majority of those deaths after that initial 6 weeks are actually due to cardiovascular causes. So really important to think that these otherwise relatively young, healthy patients can have significant cardiovascular disease and cardiovascular mortality, primarily from cardiomyopathies, and a really important consideration, particularly for those that don't do obstetrics routinely and may encounter these patients periodically. Next slide, please. So when we look at all the maternal outcomes and the reports from the MMRC, one of the things the MMRC has recognized that there are opportunities for providing care and potentially stabilizing, treating, and preventing death that occur in the non-obstetric setting. Patients that show up in the ED, urgent care clinics, or are attended to by first responders, that some of these initial presentations provide opportunities, again, to recognize that these patients might be suffering severe morbidity and that we need to intervene to prevent maternal deaths. And actually, some of the suggestions in these reports is that we do provide education and resources to the non-obstetric clinicians to help, again, recognize, stabilize, and potentially treat, as well as a number of recommendations for transport to get patients to the right place in the right amount of time. So based on the continued worsening maternal mortality crisis, some of the information that came from the MMRC, the CDC partnered with ACOG several years ago to launch this project to enhance the recognition primarily for the pre-hospital settings, and again, to provide education and resource to try to address several of these prominent conditions. Next slide, please. So we started this by listening. We created these listening sessions with subject matter experts across a broad swath of clinicals, as well as patient organizations to listen. What were the gaps? What OB conditions were most commonly seen? What would be needed to help identify potential resources in order to help, again, recognize, stabilize, and potentially treat among the non-obstetric settings? And some of the feedback that we had is there's a lack of understanding of physiology in pregnancy and the postpartum period that can impact identification and management of these patients. The risk of complications in the postpartum period, especially again, that it can go out beyond that initial few days or initial 6 weeks. And what are some of the red flags and signs and symptoms that really need to be evaluated or recognized? Next slide, please. So we created this project, a commitment to action to eliminate preventable maternal mortality and, quite frankly, morbidity. And our goal was to really increase the awareness and the importance of the non-obstetric clinicians involved in this care, again, because patients will present in those environments. And the key thing is improving identification of the patients, particularly going out to 12 months. And one of the key questions that comes from that is asking if the patient is pregnant or if she's been pregnant within the last year, because depending on what the concern might be, that should really flip a switch that the clinician needs to think differently and approach the patient differently because of the potential risks and what might be needed. And our goal, again, was also to enhance readiness among the non-OB providers to provide the resources for identification and stabilize patients that present with an obstetric emergency. The initial phase of this was chaired by an OBGYN as we went through more of the listening phase and the early development of the resources. And then our phase now with further development and dissemination of the resources, we are incredibly fortunate to have Jenna partner with us and lead us as we continue to advance these materials and again, get them in as many hands as we can. Next slide, please. So before we talk about the guidelines, we're going to talk a little bit about physiology. And I know this is everyone's absolute favorite topic, but it really is critically important to understand some of the physiologic changes that occur in pregnancy, both in normal pregnancy as well as abnormal pregnancy and pregnancy complications, to understand why we use the criteria we do, why we use the signs and symptoms we do, and even more importantly, to recognize that some of the things that may not be important, for example, if I walked into an ED with elevated blood pressures that are critically important to recognize for either pregnant or postpartum, immediate postpartum patients. So from a cardiovascular perspective, cardiac output significantly increases during pregnancy, particularly closer to term. Heart rate goes up, but systemic vascular resistance decreases, and that actually helps to stabilize blood pressure through pregnancy. There's a relatively hypotensive, so to speak, state, particularly in the second trimester. Uterine blood flow dramatically increases and is up to 10 to 15% of maternal cardiac output. Another really important consideration is uterine blood flow is totally based on cardiac output and blood pressure. It's not auto-regulated. And if you think about that, that's a physiologic adaptation. We don't want, for example, after Thanksgiving meal, for all the blood flow to be redirected to the gut and none going to the uterus. So that it's really important that uterine blood flow is maintained. And there's significant further changes during labor and particularly around delivery. Pregnancy is a hypercoagulable state. There's a combination of venous stasis and increase in coagulant production, as well as decreased fibrinolytic activity. Important physiologic adaptations to prevent excess blood loss, but it also creates the higher risk of VTE in pregnancy. There are respiratory changes. There's a physiologic respiratory alkalosis that occurs in pregnancy, but a significantly increased oxygen consumption. And actually, pregnancy is sometimes viewed as a stress test for determining underlying cardiovascular disease because of that increased oxygen consumption and cardiac output. And there are also significant renal changes such that a normal creatinine in pregnancy is actually significantly lower than it probably is for most normal adults. Next slide, please. Importantly, and I know we're not really spending much time on the cardiovascular complications in pregnancy, but there are a lot of normal changes in pregnancy that mimic cardiovascular disease, and the list is there: dyspnea, orthopnea, fatigue. There are some concerning signs and symptoms, but this makes it really challenging to evaluate patients with these symptoms to determine is just this normal pregnancy or is it some underlying cardiovascular disease. But again, it's really important to not ignore these because that stress test of pregnancy can uncover underlying cardiovascular disease. And since cardiovascular conditions are a leading cause of later postpartum mortality, it's really important to recognize those and pay attention to them. Next slide, please. There are significant hematologic changes that occur in pregnancy. So the normal volume expansion is almost 40 to 50% greater than the pre-pregnant state. The volume expansion is greater than the RBC volume expansion, so that creates a physiologic anemia. But this volume expansion is another physiologic adaptation beneficial in pregnancy because it protects against the volume of the blood loss and the volume loss that occurs during normal delivery. So a good thing. And it also protects against hypotension by countering some of that decrease in systemic vascular resistance mentioned earlier on. So again, these adaptations are generally good things. However, next slide, please. It does have an impact on the assessment of hemorrhage. So again, that volume expansion, hypercoagulability is protective against hemorrhage, but it does hide the signs and symptoms of hypovolemia and shock. And in fact, you may not see hypotension and tachycardia in the setting of postpartum hemorrhage until patients have already lost 20 to 25% of their blood volume or 1,500 cc's of blood loss. And unfortunately, blood loss is often underestimated. And by the time patients do present with signs and symptoms more classically associated with hypovolemia and shock, they've already lost, again, a significant amount of blood. And by then, and instituting fluid resuscitation as well as transfusion, you're playing pretty significant catch up. And that's even further magnified in patients with underlying cardiac disease. So that impact, the hemorrhage aspect is real, it's considerable. And even though, again, you do have a little bit of a buffer because of the normal volume expansion, by the time patients are symptomatic, it's already a real challenging issue. Next slide, please. So now we talk about hypertensive disease and preeclampsia, that some of those normal physiologic changes don't occur. So first of all, the volume expansion that occurs in normal pregnancy doesn't occur in preeclampsia. Preeclampsia is also characterized by vasospasm. So these patients don't have that adaptive or protective volume expansion, and therefore they even are at greater risk in the setting of postpartum hemorrhage. In preeclampsia, colloid oncotic pressure is decreased, which leads to an increased risk of pulmonary edema. Because they don't undergo that same volume expansion, they're hemoconcentrated, which actually leads to a potentially falsely reassuring hematocrit in the setting of hemorrhage. So in a preeclamptic patient, the quote almost normal hematocrit may actually not be reassuring at all, and it's really important to recognize that these patients are at significant risk of shock when they do have postpartum hemorrhage. And then certainly last but not least, because of the vasospasm, these patients have significant impacts on renal blood flow and actually an elevated creatinine. Even what might be normal in other adults is considered abnormal in pregnancy and preeclampsia. Next slide, please. Related to preeclampsia, it's also important to recognize the physiologic changes that occur in the cerebrovascular system. So in normal pregnancy, again, the cardiac output increases, systemic resistance decreases, and there's a normal blood pressure. The effects on cerebral blood flow and cerebral perfusion pressure are poorly understood, but it's believed in normal pregnancy that the blood flow actually might decrease slightly. It's also important to recognize that the cerebral arteries normally undergo a medial hypertrophy, which actually protects the blood-brain barrier in the settings of higher pressure and protects against hypertension. This hypertrophy and adaptation is actually lost in pregnancy, which creates higher permeability of the blood-brain barrier and a higher risk of edema, even in normal pregnancy. Next slide, please. However, when you bring in preeclampsia, these patients might have elevated both blood flow as well as perfusion pressure, likely because of the elevated blood pressures that occur. And at the same time, they have the decreased cerebrovascular resistance. Furthermore, these patients have loss of cerebral blood flow autoregulation, which further impacts hyperperfusion status in the brain. The blood-brain barrier permeability is decreased and therefore leads to an increased risk of edema. And when you put all this together, it's actually similar to the changes seen in hypertensive encephalopathy. And in fact, it's felt that preeclampsia represents a form of posterior reversible encephalopathy syndrome that is seen in these patients. Next slide, please. So why is all this important related to the concerns we have in hypertensive emergencies? It's basically because of the risk of stroke. These encephalopathic changes that occur in preeclampsia occur in lower blood pressures in pregnant and postpartum patients than it does in the non-pregnant population. And that combination of impaired cerebral autoregulation, hypercoagulability, as well as inflammation that occurs in preeclampsia, which can also affect the cerebral vascular response, leads to higher potential for stroke at lower blood pressure as compared to the non-pregnant and postpartum patients. And that includes both ischemic and hemorrhagic stroke. So we're often asked why the blood pressure criteria we use to define a hypertensive emergency are lower in pregnancy and postpartum, again, compared to, for example, if I walked into the ED with elevated blood pressures. And it's all because these changes that increase the risk of stroke in pregnant and postpartum patients occur at lower blood pressure thresholds. So that's the end of the physiology lesson for today. Again, really appreciate and hope that this provides some understanding of why we use the criteria and the approaches that we do. So I'm going to turn it over to Jenna to talk about the guidelines. And again, thank you very much, Jenna, for your incredible contributions and leadership to this project for several years now.
Thank you, Chris. It's certainly been an honor. Good morning, good afternoon, everyone. As was mentioned at the start of the webinar, I'm an emergency medicine physician and an EMS physician in New Mexico. I've taught in various capacities at UNM's EMS Academy for about 13 years now. And I'll be talking about how we as EMS educators can improve our teaching of obstetric topics to EMS learners, both through content and character. And as Chris so nicely outlined for us, there is some physiology that's very unique to pregnancy, much of which is actually protective and adaptive on some level, but some of which can actually factor into disease states. Next slide, please. So let's consider a few pregnancy-specific complications and highlight some of the important educational elements that we feel are important to emphasize for EMS learners at every stage of the educational journey. Next slide. We'll start with postpartum hemorrhage. So despite its reputation for being kind of a messy experience, childbirth should not be a gigantic bloodbath. And any significant bleeding after delivery really should be a cause for concern. So that's kind of a crucial concept we want to convey, is that if you have a mom who has just delivered and continues to have significant vaginal bleeding, that is problematic and needs to be addressed. And also, vital signs are certainly vital, but in pregnancy, they will betray you and therefore betray the patient. You cannot rely on vital signs to make the diagnosis of postpartum hemorrhage. If you wait for your patient to become tachycardic, or certainly if they become hypotensive, they will have already lost a very significant amount of blood, and you'll be really behind in your resuscitation, perhaps irrecoverably so. As Chris mentioned, the blood volume increases significantly in pregnancy, and so you can lose a lot of blood before you begin to see any changes in the hemodynamics. So you really have to rely on detecting and measuring ongoing blood loss in order to recognize and treat postpartum hemorrhage promptly. Next slide, please. We also need to understand what underlies postpartum hemorrhage at the physiologic level. Uterine atony is far and away the most common cause of postpartum hemorrhage. And so after an EMS clinician recognizes that they have a patient with a postpartum hemorrhage, the next step is to understand that this is most likely due to uterine atony, a failure of the uterus to contract back down after delivery. And as Chris mentioned, the uterus during pregnancy, especially at term, has just a tremendous blood supply. We're talking 10 to 15% of the maternal cardiac output supplying the uterus at any given point in time. And so you have a tremendous amount of blood flow being fed into the uterus. And if that uterine musculature doesn't immediately start to contract back down and really kind of constrict the spiral arteries of the uterus, the potential for an exsanguinating degree of hemorrhage is really quite significant. So prompt action to promote an increase in uterine tone is super key in the management of postpartum hemorrhage. Next slide, please, Nina. Okay, so how do we go about doing that? One strategy that is not here on the slide, but that is still super important is uterine fundal massage. This is the technique of palpating the top of the uterus, called the fundus, through the maternal abdomen. So placing a hand on mom's abdomen and feeling for the top of the uterus. In a term pregnancy, this is going to be above the umbilicus. And if there is in fact uterine atony, the fundus may feel somewhat kind of boggy or squishy. When I'm teaching this topic, I use the analogies of like a sort of semi-inflated volleyball, or if anyone has like school-age kids, the like Squishmallow stuffed animals. It's kind of just this squishy, boggy thing that is in the maternal abdomen, and at term, that's going to be above the umbilicus. Versus a uterus that is beginning to contract down appropriately should feel almost as firm as like a softball. The difference is really that pronounced. So if one hand is placed at the fundus and the other hand just above mom's pubic bone, and you feel that kind of squishy, boggy structure, then your aim is to kind of squeeze your hands together with firm pressure. And this is going to encourage the uterus to contract down as it's kind of being compressed between your hands. And this will greatly minimize blood loss. Important to note, this is quite painful for mom. And also can be kind of nauseating because of the uterus contracting down significantly, kind of creating a very visceral sensation. So just kind of be aware that nausea and potentially even vomiting can occur as you're doing this. So that is one strategy. And then we have our pharmacologic approaches. And our first line pharmacologic agent for postpartum hemorrhage is going to be oxytocin. Oxytocin is a hormone that the body produces endogenously in the hypothalamus and is then released by the posterior pituitary gland. We can augment this natural process with pharmaceutical oxytocin that can be given intramuscularly or via slow IV push after delivery. We can also administer an infusion of oxytocin as well in the setting of ongoing hemorrhage. Another approach is to use misoprostol. Misoprostol is a medication that many emergency type folks probably don't know much about. This is a prostaglandin E1 analog that promotes uterine contractions. And in many ways, this is an ideal EMS medication. It can be stored at room temperature without refrigeration. It has a long shelf life, and it's absorbed mucosally. So it can be administered just by placing the medication in between the patient's cheek and their gums, or it can be administered vaginally. So very simple medication to administer and a good option for folks who are facing long transport times between, say, the patient's home and an obstetrically equipped hospital, or just a good option to have if you're faced with a patient who continues to bleed despite administration of oxytocin and fundal massage. Any discussion about postpartum hemorrhage would be remiss without mentioning TXA. Postpartum hemorrhage is probably one of the best indications for the administration of TXA in terms of its efficacy. So if you have a patient who is having ongoing bleeding that does not respond promptly to those interventions we've described so far, I would reach for TXA. Blood products are also a crucial element of treating postpartum hemorrhage. As I mentioned, the degree of bleeding can be very significant for these patients. And so if you have access to blood products either in your system or can have an intercept with an agency that carries them, or you can utilize a flight service, for patients who certainly are developing signs of hemorrhagic shock, blood products are going to be an important part of the pre-hospital treatment for these individuals. Next slide, please. Okay, let's talk about eclampsia. So the diagnosis of eclampsia really has to be somewhere in the back of your mind for any patient who is capable of pregnancy and has a seizure. And so for all of you as educators, incorporating the consideration of eclampsia as the etiology for a seizure is clinical decision making that ought to be included when you teach seizure. We learn about many reasons why people have seizures: hyponatremia, head trauma, hypoglycemia. And really, in a pregnancy capable individual who seizes, you have to wonder, is there a chance that this person could be within 6 weeks postpartum or greater than 20 weeks pregnant? And this is actually, this seizure is actually a manifestation of eclampsia. And also, not all eclampsia is preceded by a long, tumultuous course of preeclampsia. There is a subset of patients whose presenting symptom for their hypertensive disorder of pregnancy is in fact an eclamptic seizure. So they don't necessarily have to know before they have a seizure that they have preeclampsia, as that can sometimes be a very rapid clinical development over a short period of time. Next slide, please. And as Chris sort of outlined, there's some complex pathophysiology at play here. And it's an area that has not been entirely elucidated, but know that eclampsia is a serious end organ manifestation of a multisystemic disease process. And so it needs to be treated very aggressively. Next slide. That said, our initial priorities for patients with seizure are always the same. We want to protect the patient from further injury. We want to protect the patient's airway, ensure that they're oxygenating, and still, of course, check a blood glucose measurement. We also want to make sure if that a patient has an obviously gravid abdomen, that we're performing left uterine displacement so that we're shifting the weight of that uterus off of the vena cava and allowing blood return to the right side of the heart. Next slide. So how do we treat eclampsia? Well, administration of magnesium sulfate is a clinical priority for these patients. Many eclamptic seizures will stop on their own. However, administering magnesium prevents additional seizure activity and may also have some other neuroprotective benefits as well. So magnesium administration is crucial as soon as it's recognized that this patient has likely had an eclamptic seizure. And we acknowledge that there is a subset of patients who are likely to receive benzodiazepines before the possibility of eclampsia is really recognized, and that's okay. But even if they've gotten benzos, even if the seizure has stopped, we still need them to get mag sulfate. The administration of mag starts with a bolus of 4 grams if the patient has IV access, and then an infusion will then be initiated after the bolus is complete. There is the option of intramuscular administration for patients who do not have IV access, and that's a substantially higher dose of 10 grams that's going to be split into 2 separate 5-gram injections between 2 large muscle groups. Importantly, particularly during the administration of an IV bolus of magnesium, patients can experience some unpleasant symptoms. They often will feel this sense of like warmth or heat kind of washing over them. They can have some flushing, almost like a burning sensation, and can feel very restless. This does get better after the infusion is completed, but just to provide the patient with some anticipatory guidance that that particular 4-gram infusion over a fairly short period of time is a little bit unpleasant. The second big point to make regarding eclamptic seizure is that if the patient is hypertensive after they stop seizing, blood pressure control is another very important step in the management of these patients, which is a nice transition to our third pathology. Next slide, please. Elevated blood pressure during pregnancy or early postpartum. So a really important consideration to teach in obstetrics is the approach to the patient with elevated blood pressure. And we're talking about patients who are beyond 20 weeks gestation or within 6 weeks postpartum. So crucially, our threshold for concern about blood pressure is simply different in pregnancy than it is with other populations. We start to worry about things like preeclampsia and subsequent risk for eclampsia at blood pressures of 140/90, especially if that elevated blood pressure is accompanied by worrisome symptoms like headache, blurred vision, right upper quadrant abdominal pain, or epigastric pain. If the pressure has reached 160 over 110, the patient has very possibly met the diagnostic criteria for preeclampsia with severe features off blood pressure criteria alone. Next slide, please. And I think this is truly an area where EMS educators can make a huge impact by removing some of the exceptionalism that exists around pregnancy and vital signs. So when vital signs are being taught in an EMT class, for instance, let the conversation around blood pressure norms include a discussion about blood pressure norms in pregnancy right from the start. Don't let the difference in blood pressure numbers be something that has to be unlearned, so to speak. Next slide. So there are huge potential benefits to lowering a patient's blood pressure when it has reached a problematic level during pregnancy. Many years ago, we used to lower blood pressure acutely for non-pregnant patients who had elevated blood pressure and symptoms. And that did not go well. We definitely harmed people whose bodies and whose organs had adapted to high perfusion pressures. And when we abruptly took all of that away, we caused major problems like strokes and MIs and hypoperfusion of the gut and the kidneys. So we don't do that anymore in non-pregnant patients outside of a few very specific circumstances like aortic dissections. But once again, the physiology of pregnancy is so different. And lowering blood pressure acutely in patients who are greater than 20 weeks pregnant or less than 6 weeks postpartum actually confers a lot of benefit to these patients, or at the very least protects them from further harm. We've seen some epidemiologic research suggesting that pregnant patients with delayed achievement of blood pressure goals were at heightened risk of complications like shock, renal failure, and stroke. So this really is a time-critical disease, and therefore treatment of elevated blood pressures in pregnant and newly postpartum patients really does fall squarely in the EMS realm to prevent mortality and morbidity. So we do recommend that patients' blood pressures be lowered moderately within 30 to 60 minutes of identification, acknowledging that some of the medications we might use to do that may be outside of the scope of practice for the level of licensure you may be instructing, or perhaps that these medications aren't available to EMS in your state at all. But if they are, and you can connect a patient to someone who can give these medications promptly, that really is the goal. I'll point out that we are talking about, for blood pressure lowering, two medications that are given IV. Those are hydralazine and labetalol. But there's also a PO medication option in nifedipine. So even for levels of EMS licensure that don't include the capacity to start an IV on someone, there's an option to administer an antihypertensive PO, which is really great. Next slide, please. And so to help frame the key points related to these three pathologies in particular, and to prevent some of this information in a way that is very familiar to EMS folks, I did want to share with all of you a key deliverable in the ACOG OB Emergencies project, and that is model EMS guidelines for the treatment of these conditions. These guidelines provide general information about each of the conditions I just spoke about. It breaks out key actions for all EMS clinicians and for those who are licensed at more advanced levels. I did not discuss medication dosages specifically in my previous slides in an attempt to avoid getting too much into the weeds on each of these topics, but all of your medication dosages are given here in the guidelines as well. So we have our postpartum hemorrhage guideline. Next slide, please. Our eclampsia guideline. And then probably our most comprehensive guideline, next slide, is the elevated blood pressure guideline. You'll note that there's kind of color coding to indicate which patients are potentially at the highest risk for harm. And those color codings will persist throughout the guideline to help identify what ranges of blood pressure and or symptoms we're talking about when we consider each of the interventions outlined in the guidelines. Next slide, please. So please take the time to look through those. The QR code here will allow you to access those resources, or you can simply visit the website here, acog.org/OB Emergencies. The guidelines are available in Word and PDF forms, so feel free to take a look and share them widely. Next slide, please, Nina. So, switching gears slightly, I wanted to talk about the culture of EMS education as it relates to pregnancy and obstetric emergencies. And what is our role or even our responsibility as EMS educators when we present this topic to learners? Because this can be a challenging topic to teach, frankly. These calls are often uncommon in the pre-hospital setting. And so, as educators, we often personally have kind of a lack of personal experience treating these patients on which to draw to therefore teach our learners about this subject. It certainly involves some sensitive anatomy, which can create some discomfort in the classroom at times. And what I have sometimes observed when I've taught this topic to EMS clinicians is that there's a lot of apprehension and, frankly, even terror surrounding this topic. Many EMS clinicians have so much fear and anxiety about the possibility of having to manage an obstetric emergency in the field that it almost creates this like mental block in their minds about it, where they have a hesitancy to even learn about it. Kind of like if I don't even like engage with this content or don't like touch the mannequin, then like I'll somehow be protected from ever having to do this in real life. And this is certainly not every learner, but I definitely, whenever I've taught this, I've had like a few students who are just like, I don't want anything to do with this. And this is my own perception, of course. But I suspect that other EMS educators have had similar experiences. And in fact, ACOG and the National Association of EMTs conducted a survey of more than 1,700 EMTs and paramedics that confirmed exactly what I'm describing, that there's a discomfort and a lack of confidence around the topic of pregnancy-related emergencies. And many folks describe having learned some of this content in their primary EMS education and then haven't really revisited it at all for many, many years. And if I ask a room full of EMTs and paramedics, what's one call you never want to run? I guarantee you someone will say, I never want to deliver a baby in the field, or I never want to have a delivery complication in the field. So as EMS educators, knowing this pattern of fear, of lack of confidence, of stress, or even avoidance around this topic within students of the EMS profession, what are we to do? What is our responsibility? Next slide, please. So I view that responsibility as twofold. One is to train deliberately and rigorously on the recognition and the management of obstetric emergencies, both initially and on an ongoing basis. And secondly, to reflect on what sort of classroom culture we're creating when we teach these topics related to pregnancy or to obstetric-related problems. So on the training front, I think that there are a few strategies to increase learner competence and therefore confidence. One would be to consider the design of the curriculum. In many ways, I think it makes a lot of sense to have a segment in the class schedule where OB emergencies are discussed in block. I think this is especially true if you are making use of a birthing mannequin, which may need to like come from somewhere else, or maybe you have to bring your students to some sort of sim lab for a period of time, or maybe you're fortunate enough to have an OBGYN come in and teach part of your class. And it's probably a lot easier to get a single larger chunk of that person's time rather than trying to spread their participation out over many months or weeks. So there's a lot of benefit to taking this topic and covering it in depth in one segment. However, I do think it's helpful to include pregnancy-related complications throughout your courses whenever it's relevant. So, for instance, bring hypertensive disorders of pregnancy back into discussion during the cardiovascular block if you do a systems-based approach to learning. Discuss the possibility of eclampsia when you're talking about seizure and remind everyone of the treatments for these things. Throw some postpartum hemorrhage simulations into your trauma block to relate those hemorrhage management skills back to a different type of patient. Doing so creates some natural spaced repetition in your curriculum and kind of forces the idea of possible pregnancy-related pathology into students' minds in situations where patients are perhaps less differentiated. Deliberate practice is also key when we're talking about these high acuity, low occurrence, high stakes clinical situations that we don't see every day. Your students in real life are not going to get daily practice delivering babies in a breech presentation, or any presentation for that matter, or mixing up a magnesium infusion, for instance. So deliberate practice of these skills is important, getting some sets and reps in during their education to develop competence. This quote has been attributed to many different people, but there's a saying, don't practice until you get it right, Practice until you can't get it wrong. And while I think this is a little bit like hyperbolic in some ways, I do think with these sort of halo events, these high acuity, low occurrence situations, it requires more than just doing this one time in class and checking the box and then never revisiting again. Next slide, please. Secondly, I think we should ask ourselves, as an EMS educator, what narrative am I creating around this topic in the classroom? Am I speaking about pregnant patients with a tone of voice and using language that promotes my students to feel empowered or disempowered in treating patients with these conditions? Am I only speaking about or telling stories about how horrible or terrible these situations can be or how bad they can go? Do I have dread in my voice when I discuss this topic? And I think an interesting parallel for us to reflect on is the performance of out-of-hospital cardiac arrest resuscitation. Despite the fact that, on average, in the US, patients who experience an out-of-hospital cardiac arrest have a 10% or less chance of leaving the hospital neurologically intact, we don't often speak about cardiac arrest resuscitation with the same degree of dread and defeatism that I often hear associated with any discussion on pregnancy or delivery in the out-of-hospital environment. And while we are certainly here today in large part to impress upon you the importance of recognizing when things go bad and recognizing those pregnancy-related complications and emergencies and being really timely with your treatment of them, most patients, even those who deliver in kind of an unplanned fashion outside of the hospital, will do quite well. And I get it. In obstetrics, there's two patients. The pregnant individual is usually someone who's young and healthy. Babies are a whole other population that we don't see a ton of, especially like neonates. So you're dealing with two patient populations that we just don't have a ton of experience in. I understand that. But if we think about the complications, even the ones we've described here, the treatments that we've outlined are in fact very effective. And when patients with complications are recognized and treated, they do often do very well, often far better than some of the other types of patients for which we devote a very large amount of resources and time in our curriculum too. All that to say is that we should have ourselves and impart to our students a healthy respect for the complications of pregnancy and the importance of detecting them early, but also realize that there actually is quite a lot we can do with treatments that are actually very effective to significantly improve the likelihood of a positive outcome. Next slide. So as educators, I feel we have a responsibility to share responsibly. If the only story you have to share about a particular class of patients, let's say in this case, since we're talking about obstetric emergencies, we'll talk about obstetric patients. If the only story you have to share is one where you had a bad outcome or where you did feel very disempowered and afraid, tell that story, but also share what you learned from that case. Take your students through how you process that call, what you did to seek out additional resources or training after the fact. How would you manage it differently or better today? How have you been resilient in the face of this challenge? I think it is so helpful for students to see or to hear about the ways in which their instructors and their mentors have struggled or even failed. But I think you can close that loop, so to speak, when you share what you learned from that difficult experience and can say, this is why I'm teaching you some of these skills now, because I know firsthand that these can be tough calls. And I want you to have every tool that you need to do this well. And I think that is where the real power of storytelling lies, when we can have a sense of tragic optimism about these really hard calls. Because I want to make clear, I'm not talking about being toxically positive about clinical situations that can frankly be very difficult and certainly trauma-inducing to clinicians when things don't go well, or even if they do go well. I will never say that there's no place for storytelling or no place for gallows humor, because there's a lot of vicarious trauma that is incurred in this job. And I think it is really important to have a culture that supports those mechanisms of relieving stress and of sharing our feelings of, terror when taking care of a really sick patient or a patient that we felt less than equipped to care for. However, I think we can do that. We can acknowledge that fear, that uncertainty, without establishing kind of a fear-mongering narrative that sets EMS clinicians up for a career-long pattern of avoidance and disempowerment when it comes to the care of pregnant patients. because that fear and that avoidance holds people back from doing the things that are potentially life-saving. And we've seen this. The MMRC reports that Chris mentioned at the start of our time today were based upon actual maternal deaths and included recommendations for EMS clinicians to be better prepared to recognize and treat pregnancy-related emergencies. There were real patients who were treated by real EMS clinicians, and in some cases, it was recognized, and unfortunately, after a maternal death occurred, that there may have been a missed opportunity for those EMS clinicians who cared for that patient to better recognize and treat that pregnancy-related pathology. So let's decide together today that the very next time we're in front of a classroom or precepting a student in the field, that we are going to rise to the challenge to do our part to prevent maternal mortality and morbidity. Next slide, please. So thank you so much for tuning in today and spending this time with us. It's been really wonderful to have this conversation with all of you. And I think we are going to open it up for questions at